I would like to introduce Professor Thomas Leung from Hong Kong. He is a specialist in intervention radiology. Now he will present pathogenesis-based ICAD management. Please. Thank you.
Trong chương trình này có được.
So it's very important to emphasize at the beginning that not all indicators of diagnosis are arteriosclerosis. I can show you some examples here. On the left-hand side, you can see Wong syndrome, very common in Asians, associated with mutation in the RNF213 gene and developmental. Okay, the patients may get progressive stenosis of the distal internal carotid artery or middle cerebral artery. Okay, Moy syndrome. On the second left is the dissection. Okay, in a patient without cardiovascular risk factors. Okay, female patient, young female patient develop middle cerebral artery dissection. So actually you can see here the dissecting flap. Okay. It may appear like a stenosis in the angiogram. In this patient, concentric stenosis of middle cerebral artery, they're actually autoimmune disease or primary angiitis of CNS. And eventually, the stenosis improved with steroid, with immunotherapy. So they're autoimmune in origin. Of course, there could be other inflammatory cause of the vasculopathy. And the commonest, I think, in this region would be like tuberculosis-related stenosis. And sometimes you can see here, it may appear like a stenosis in the CT angiogram or MR angiogram. But actually, if you look closer in this three-dimensional rotational angiogram, you can see there's a fenestration here. Is a stenosis right proximal before a fenestration. So you have to appreciate this anomaly, or else if you subject the patient to endovascular treatment, it may lead to catastrophic consequence, severe complications. So not all stenosis are atherosclerosis in origin, but still ICAD is still the commonest cause of ischemic stroke in this locality. So ICAD had its distinct pathoanatomy. You can appreciate this, this histological section of a middle cerebral artery, the eccentric plaque, a very thin fibrous cap with hemorrhage and lipid deposition within the plaque. Compared to extracranial vessels of the neck, you can see the medial layer is inconsistent and the adventitia is very thin. So it's very fragile. So in case, if you imagine we perform endovascular procedures within these vessels may easily bend and conform to the curvature of the catheters. And therefore, if you advance these catheters or wires inattentively, it may cause jumping of the wires, leading to rupture or avulsion of the distal branches. More important here, you appreciate the perforators coming out. So in the middle cerebral artery, it is lenticulostriate arteries. In the basilar artery, these are the perforators coming out. So remember, in Sampras study, medical therapy is superior than endovascular treatment. Why? Because one of the major complications in Sampras is perforator stroke. So these branches may coming out from a stenotic segment. So if we do balloon angioplasty, we inflate the balloon, those plaques may smear over the opening of the perforators, leading to what we call the perforator stroke. So this is a very important complication we have to prevent. So in the coming few minutes, I'm going to discuss with you 5 important aspects in the pathogenesis of ICAD that may change our concept about the management of ICAD. So first thing is the diversity of stroke mechanisms and their prognostic value. So the ICAD definitely is not a single disease entity. There are several stroke mechanisms of ICAD that can result in ischemic stroke. First of all, is the parent artery occluding a perforating artery or an adjacent branch. Like in this patient, a very high-grade basilar artery stenosis, you can appreciate here. But at the same time, you see the opening or the ostium of these superior anterior inferior cerebellar arteries was partially occluded by the plaque. Okay, this is a very important stroke mechanism and often result in lacuna syndrome in ICAD. The next common stroke mechanism is artery-to-artery thromboembolisms. And these tiny emboli coming from unstable plaques will usually register as high-intensity signals in the transcranial Doppler ultrasound. And these tiny emboli could be stranded in the border zone region, give rise to rosary-like infarct in what you see in the DWI MRI. The next common stroke mechanism, of course, is distal hypoperfusion because of the very high-grade stenosis. And the fourth mechanism is like a Venturi effect. Here you can appreciate the angiogram on the right-hand side. You can see here, before angioplasty, we did not realize there was actually a perforator here. Because if you remember your high school physics, if there's a very high jet through this stenosis, it will lead to hypoperfusion of the branch, the decrease in perfusion. And therefore, with this high velocity jet across the stenosis, it seems that the perforator did not appear. But after standing in angioplasty, you can see a very robust perforator came out. So be very careful. There could be Venturi effect leading to this perforator hypoperfusion. But of course, the multiple mechanism may combine in a single patient. So in this study, my colleague stratified a group of high-grade ICAD stenosis patients and into different stroke mechanisms. And she correlated the clinical outcome in the first 12 months with the stroke mechanisms. Very interesting, you can see here, if patients have artery-to-artery thromboembolism combined with hypoperfusion as a stroke mechanism, they had the highest chance of developing a stroke or TIA in the coming 12 months after the index stroke. And this mechanism actually was very common in patients. About 40% of patients have this combined stroke mechanism. So the second important pathogenesis of ICAD will be the dynamic progression or regression of plaque. So ICAD is definitely not a fixed stenosis. Okay, in this prospective study, we recruited 50 patients with very high-grade symptomatic stenosis. So we treated them aggressively with medical therapy. Here you see systolic blood pressure less than 140, the low-density lipoprotein less than 70 milligram per deciliter, which is less than 1.8, the hemoglobin A1C less than 6.5%, quit smoking, etc. So we performed 3D angiogram at baseline and in 1 year. So here are the results. It shows that ICAD is not a fixed stenosis. On the graph on the right, on the left-hand side, you can see here, this is the baseline. So all stenosis is more than 70%. Okay, you see the blue line there. But 1 year later, actually, the green line shows that nearly half of the patients have significant regression in their stenosis, more than 10%. And overall, the mean stenosis regressed from almost 80% at baseline to 63% in 1 year. And actually, less than 4% of patients have progression more than 10%, even with medical therapy alone. So higher hemoglobin A1C at baseline predicted regression in 1 year. So please control the diabetes of your patient strictly. Okay, those patients could develop recurrence. Most of them had artery-to-artery thromboembolism. This substantiates our treatment with dual antiplatelet therapy at the recurrence. So these are 4 patients recruited at baseline. Their stenosis was circled by red here, you can appreciate. And in the last patient, you can even appreciate there's an ulcerative plaque. Okay, it's a plaque hemorrhage. There's a plaque rupture with hemorrhage within. You can see the contrast within the plaque. So in 1 year, you can see significant regression of their stenosis. You can even see healing of the ulcer in the last patient. So in contrast, on your right-hand side is a patient who developed recurrence very quickly after the index stroke. Here, what you see here is the first stroke. You can appreciate the plaque morphology here, and leading to this stroke. And the lower panel, you can see just within 3 weeks, okay, despite dual antiplatelets, there's a recurrence. And we perform the 3-dimensional rotational angiogram again. Here you see a change of the plaque morphology. It's different, okay? Something must have happened, but it's not remodeling. So what happened? We postulated there's another plaque artery-to-artery thromboembolism occurring, leading to another second ischemic stroke in the corona radiator. Okay, so this is very important. You reinforce your antiplatelet treatment during the acute stage. So the third important pathogenic aspect will be the vulnerability of the plaque. So in carotid artery disease or coronary artery disease, morphology is very important. And some morphological features are actually strongly related to the lesion vulnerability and may predict clinical events. However, the plaque morphology was virtually unknown in ICAD. So what we can do our best is to perform 3-dimensional rotational angiogram to see the plaque morphology. And of course, it was an invasive procedure. We have to do it through our catheter over the groin area, puncture over the groin area, put in the catheter, and inject the contrast at the neck vessels to appreciate these morphological changes of the plaque. But you can see here, there's an infinite angles that we can appreciate the plaque. So it's a very useful tool to appreciate plaque morphology. So these are the morphometric parameters we actually measure. For example, we can appreciate the plaque surface, whether it's ulcerative, smooth, or irregular. We measure the length and the plaque thickness, like here, doing mathematics. And we measure the upstream plaque shoulder, which is important, because if the upstream plaque shoulder is huge, then the plaque will subject to a very high mechanical shear force, and they may be prone to rupture. And we also assess the plaque low, whether it's in the proximal 1/3, middle 1/3, or distal 1/3 of the plaque. And we also assess the orifice of the penetrating arteries, okay? For example, let me see, like in this patient, you can see a perforator coming out very close to this plaque, but the ostium is still intact, okay, it's not affected. In contrast, you see the patient below here, a very high-grade plaque over there, but you didn't really see the ostium of the perforator. We suspected that there could be perforator disease associated with this plaque. So we also measure the eccentricity of the plaque. As I mentioned, there will be less shear stress over the plaque surface if the plaque is more concentric. So in this cross-sectional study, we found that ulceration is an imaging evidence of plaque rupture. So ulceration here is strongly associated with the plaque thickness, upstream plaque shoulder angle, as well as the adjacent branch arthromatis. If there's more branch arthromatis disease, is associated with the rupture of the plaque. And also importantly, ulcerated plaque had more cumulative infarct load downstream, suggesting that this ulceration may have clinical or subclinical thromboembolism throughout or until a symptomatic stroke appear in front of you. So lacunar syndrome is a very common manifestation of ICAD. So here, you know, in the middle cerebral artery, the superior aspect, where the origins of perforators coming out will be important if you assess the plaque load of that particular ICAD plaque. And for the basilar artery, it will be important to assess the lateral walls, could be important because those perforators will come out laterally. And the maximum plaque load characteristically in ICAD, which is more vulnerable, when we found in the latest study, is when the plaque load skewed to the distal aspect, the distal 1/3 of a plaque, then the plaque is prone to plaque progression and clinical recurrence. So after this cross-sectional study, we then follow up this group of patients 1 year, We exercise the same stringent criteria or goals in the risk factor management, and we define the primary outcome as the relevant ischemic stroke or TIA relapse in the first year, and another primary outcome will be the plaque progression in the follow-up 3DRA, which is more than 10% in the luminal stenosis, or there's new ulceration with or without clinical relapse. And then we perform the morphometric assessment of the paired 3DRA in a blind sequence. So here are the results. We recruited 97 patients for this study. So majority of these patients had MCA stenosis, 76 patients, and 11 patients of terminal ICA stenosis, 8 in the basilar artery, and 2 is a long segment of stenosis involving the C7 and also M1. We performed baseline 3DRA approximately 4 weeks from the index event. And all 97 patients completed the clinical follow-up, but 2 patients declined follow-up 3DRA because of the invasiveness. So here is the clinical outcome of these patients. So what I circled here is the primary outcome. So 17 patients had a relapse of the recurrent stroke or TIA within the first year. And 9 patients developed plaque progression, with or without clinical relapse. So let's focus on this two groups of patients. So overall, regardless whether you have a clinical event or not, there are 3 important morphometric parameters actually have shown significant regression. First one is the severity of stenosis here. Severity of stenosis significantly regressed from 77 to 66. The plaque thickness also significantly regressed, and also the plaque, the upstream plaque shoulder, suggesting that the plaque regress and decrease its vulnerability. So on your right-hand side are those patients without clinical relapse. You can see majority of patients have significant regression in terms of the stenosis, the change of percentage stenosis in 1 year. And some patients don't know why their lesion continue to progress, but still despite the progression, they did not develop any clinical recurrence, and perhaps because we buy time for the development of the collaterals. On your left-hand side, we see a group of patients with clinical relapse. But very interesting. Despite early relapse, you see about 50% of patients still have significant regression in 12 months. And therefore, early clinical relapse did not preclude later regression of the plaque. So still you have to control the risk factors of your patients very stringently. So overall, if you see the risk factor control between patients with ICAD progression or without ICAD progression, they're actually very comparable, okay, despite the same goals of treatment. So there are three important morphometric parameters that may predict clinical relapse and predict ICAD plaque progression. They're namely the smaller plaque shoulder, the upstream plaque shoulder, the higher plaque thickness, as well as when the plaque burden skewed to the distal one-third of the plaque. And if we put these three morphometric parameters into a predictive model, this model is highly predictive of ICAD progression. So we turn to the fourth pathogenic mechanism of ICAD, will be the rheology of ICAD. The reason I talk about the morphology is because the morphology will actually shape the adverse hemodynamics across the stenosis. We now know very well because in our study, based on the CT angiogram, okay, this is a computational fluid dynamic models, we know that two important parameters of relevance. First is the translational pressure ratio. Therefore, with a significant drop in the perfusion pressure across the stenosis. And the second parameter is into translational shear stress, which measured at the throat of the stenosis. These two parameters actually will predict whether this patient have recurrence or not. And with three-dimensional rotational angiogram, we can actually have a more well-calculated in terms of the flow pattern and also velocity distribution in these patients. And you can see, even measure the shear stress for the plaque, which may predispose the patient to clinical recurrence. So the last features will be the perforators within the stenotic segment. As I mentioned before, perforator stroke is a very important complication in the SAMPRESS study. So how can we prevent perforator stroke? So we actually did this study a decade ago. There are two important reminders to prevent perforator stroke. First, we did a very careful angiogram before stenting. Imagine when a metal strut is being deployed over the segment. You have to first imagine how the segment will go. It will become straightened. Will the straightening of the middle cerebral artery bend the perforators, leading to a perforator stroke? You have to well plan in advance, particularly the landing zone of the proximal and distal, your stent will be very important consideration. The second consideration will be the submaximal balloon dilatation. We do not ask for angiographic perfection. We don't need that, okay? You just need to improve that to about 70 to 80% of the original artery diameter. That's what we call the submaximal balloon angioplasty. And therefore, when you calculate or use the size of the balloon, the size or diameter of the balloon should always be less than 80% of your parent artery diameter. This is a very important reminder. And in this study, we did not encounter a single patient with a perforator stroke, even if we perform an MRI 4 months after the implantation of the MCA stent. So these are what I mean by assessment of the perforators. Here, a very high-grade stenosis here is safe if you put in a stent, but the stent will actually straighten up a bit of a segment, but this perforator will not be affected. In contrast, just imagine if you put in a stent here, the plaque material may actually smeared onto the perforator surface and occlude this branch. okay, causing a perforated stroke. So very important to be aware of this snowplow effect. So eventually, after assessing the stroke mechanism of these patients, if those patients are really refractory to medical therapy, like in these two patients, they may benefit from endovascular treatment. Like here, you see very high-grade stenosis and the anterior cerebral artery and the middle cerebral artery. You can judge from the contrast intensity, is very hyperperfused. So after stenting, you can appreciate there's even re-emergence of the anterior cerebral artery here. But in 1 year, you see some slight in-stent restenosis. In the patient in the lower panel, you can see she even enjoyed a late luminal gain by the wingspan stent. So we have to define this subset of patients. So much so for the elective management of ICAD patients. How about in the acute stage when a patient presented with an acute thrombosis, or what we call the large vessel occlusion? So in this patient, it's a common experience for a neurointerventionist. There will be acute occlusion. In the first angiogram, you can see very good collaterals. This is not a good sign, in fact, which means the patient may have this stenosis for a long time and eventually come up to a total occlusion. So here, very common scenario. After the first stent retriever, there's recurrent flow, but only in a few minutes, there's immediate re-occlusion, very common in the ICAD patients. So what can we do about this? We try to do it in a more gentle manner, or in submaximal recanalization. The reason being is that even for carotid or even intracranial stenosis, you will be very careful or gentle, even in the elective manner. So how come in the acute stage, you will have a stent retriever to have endarterectomy that aggressively, particularly when there's no antiplatelet on board? If you have that plaque removed, yes, immediate angiographic appearance will be very good, but because of the denudation of the endothelium, there could be platelet aggregation and reocclusion very swiftly. So our approach could be slightly different. Here I show you a few examples. So this is total occlusion of patients here. You can see the tapered end of the middle cerebral artery. So after the first suction, we perform suction for the thrombectomy first. So you can appreciate within the red circle a few emboli occluding in the M2. And this is the residual stenosis. You can see actually the plaque there. This is not a cardioembolic clot. So you see still soon reocclusion of the M1 segment. So what we can do is to put in distally a suction catheter, a smaller one. We clear the clots in the M2 segment first, and then we slowly retrieve the suction catheter in a very slow, stepwise manner to gently suck the platelet aggregation, along the stenosis. So this is actually the residual, original, or perhaps the original stenosis of this MCA stenosis. And probably it's good enough because the patient had a very swift recovery, within 1 day, and we started on dual antiplatelet the same day, and the patient remained well and discharged home directly on day 5. So this is another patient, 52-year-old, with NHSS 21, but aspects, full aspects, 10. So you can see very high-grade stenosis there, and even with aspiration, there's still residual severe stenosis over 90%. And the distal perfusion was very poor. So we performed angioplasty this time with 2 millimeter gateway balloon. The residual stenosis is about 50%. We didn't put in a stent because the patient did not have any antiplatelet before. And we infused integralin this time, which is in glycoprotein 2B3 inhibitor, and bolus, and then continuous infusion for a day. And we were able to achieve very rapid clinical recovery. And the resultant infarct was actually quite small. And we can actually start the dual antiplatelet therapy for 3 months on day 2 after the integralin. So this is one patient with the known to have a basilar artery stenosis, and he eventually developed tetraparesis. And we know that is likely due to the basilar artery occlusion. And because the two vertebral arteries are very hypoplastic, very thin, we're not able to put in any suction catheter. What we can do is actually put in a catheter small enough caliber to infuse intra-arterial TPA of 10 milligram. And we'll be able to recanalize the basilar artery. And the patient remarkably recover. And here is the resultant infarct, which is quite small. And very interestingly, in 3 months, we perform an MRA of these patients. Actually, the basilar artery is quite good, okay? Recanalization with very stringent risk factor control with medical therapy, okay? This patient did not receive any aggressive endovascular device management, but recovered with medical therapy alone. So my conclusion, ladies and gentlemen, ICAD is not merely a stenosis. Understanding the stroke mechanism and overall cerebral hemodynamics is critical for management. Medical therapy, that is initial dual antiplatelets in conjunction with stringent risk factor control, is the mainstay of first-line treatment. Angioplasty or stenting can be considered only in selected patients refractory to medical therapy after careful evaluation of the pathoanatomy. For ICAD-related acute-LVO, our experience suggested that gentle submaximal recanalization may avoid further plaque rupture and may minimize reocclusion. Thank you very much.
Okay, thank you for interesting presentation. Sau đây thì mời các quý đồng nghiệp có câu hỏi thì đặt ra cho báo cáo viên để chúng ta có câu hỏi. Thì mời Phó Giáo sư Thắng.
Good morning. Thank you very much for excellent talk about ICAD. I think it's one of the best lecture I have. I think ICAD is very, very difficult because you have to consider a lot of things before you consider to stand or not to stand. Mm-hmm. So, and then after you decide to stand, it depends on a lot of technical of INR. Mm-hmm. So I think it's very high risk. So a lot of speakers say, oh, we can consider to standing for refractory ICAD. But what is refractory of medical treatment definition? We don't know, right? Because it's now some guy they treat the ICAD and treat the dual antiplatelet statin, and then if the patient is they repeat the CTA or DSA, they found is the stenosis is still there or even progression, and they put a stent. They say that it's a refractory of medical treatment. I don't agree that. So I feel it's very high risk because it's not you don't have the protocol, the standard protocol for all of ICAD. So I'm worried about if we say, oh, maybe consider refractory. It's the open door for INR guys intend to put the stent, and we have a lot of trouble with the Satkai about it. Thank you.
I totally agree with you. And actually, you cannot really see the stenosis itself. It's a composition, it's the component within. Perhaps MRI may tell us later on. Because when it's inflammation, it's the platelet cap, there's a high degree of possibility that the lesion may regress on its own. But if it's a chronic lesion, high-grade chronic lesion, very calcified, is not much inflammation and hemorrhage within that, I think the lesion may be there for a long time and may cause severe hypoperfusion, and the patient could be very symptomatic and could be refractory to medical therapy. So they're totally different sets of patients that we have to distinguish in the future. Thank you.
Thank you. Tiếp theo chương trình thì I would like to invite Professor Wong from Australia. Will present heart and brain AF, atrial myopathy, PFO, LAA closure. Giáo sư Andrew Wong từ Úc sẽ trình bày với chúng ta một cái chủ đề tiếp theo, đấy là tim và não, dung nhĩ, bệnh lý cơ tâm nhĩ, còn lỗ bồ dục và đóng tiểu nhĩ trái. Please.
Thank you. So thank you again to the organisers for having us and my colleagues from the Stroke Academy join you at this meeting. I will talk about heart and brain topics. I cannot be comprehensive in this amount of time, so I will touch on some highlights and some recent evidence. Okay. So we have understood for a long time that atrial fibrillation causes stroke. We think. But there is data that is not that new, which suggests that maybe the atrial fibrillation is not the cause of stroke. So this is data you may have seen before from the ASSERT study, where they looked at the pacemaker and they interrogated the pacemaker when someone had a stroke to see when did they have the atrial fibrillation, if they had any at all, in relation to the timing of the stroke. So on the left is the figure from the manuscript. I've enlarged the middle panel because in that panel we see the line in the middle, which is the time of the stroke, and the grey bars are when the atrial fibrillation occurred. And this panel B, this makes sense. These patients had atrial fibrillation, those little vertical grey bars, within a few days, maybe a month of their stroke, maybe also before that as well. But that's what we expect to see if we think that atrial fibrillation causes a stroke. But there were other patients in this group. They had their atrial fibrillation a long time before the stroke, up to a year before, and then no atrial fibrillation until they had their stroke. So for those patients, how relevant is the atrial fibrillation to their stroke? Do we still say that their stroke was caused by atrial fibrillation? And then there's these patients. These are the patients that we admit with a stroke and we test and we find atrial fibrillation. And in this group of patients, we know they did not have atrial fibrillation before the stroke, but then after the stroke, we find the atrial fibrillation. Does that mean the atrial fibrillation was the cause of their stroke? And so perhaps we should not think too much anymore about the cause of the stroke. We don't think about finding the cause of the stroke in most of our patients. We treat everything we can treat to prevent another stroke. If we find someone has high blood pressure, that does not stop us also treating the cholesterol. If we want to start using antiplatelets, that does not mean we don't also think about doing carotid surgery. So perhaps what we are looking for is a way to find patients who will benefit from anticoagulation, not necessarily through finding atrial fibrillation, although we do know that that is one way to achieve this. So what we're looking for then is a stroke risk high enough to warrant the risk of bleeding from anticoagulation. Clearly, if we know the patient has atrial fibrillation on the left and they have a CHADS-VASc score of 1 or more, then we should anticoagulate. And we also have data from the Crystal AF study and also from the Stroke AF study that if we find the AF, we should treat those patients. I'll talk a little bit about these other studies as we go. So this is where we start. We anticoagulate if we find the atrial fibrillation before or after the stroke. Or in the patients who have ESUS, we can use the Crystal AF data to tell us that we should use implantable loop recorders to find the atrial fibrillation. Or even in the Stroke AF data where we thought we had a cause for the stroke, we still look with implantable loop recorders and we can still find atrial fibrillation. So that is one way to diagnose patients who would warrant anticoagulation. But unfortunately, at the moment, we still have to find the atrial fibrillation. We've had trials, Navigate ESUS, and Respect ESUS, where we looked at the patients who looked like they had embolic stroke of undetermined source, based on the size of the infarction and the lack of another cause on their workup. Unfortunately, in those studies, we could not use oral anticoagulation to prevent the risk of stroke in those patients. We then thought perhaps within that group of patients with ESUS, there was an enriched subgroup of patients who had ESUS but also had markers of what we call atrial myopathy. Now, atrial myopathy is still a concept which is yet to be proven. We think that the atrial fibrillation is just an epiphenomenon or a feature of the atrial myopathy, which indicates patients who have a diseased left atrium who are therefore at risk of stroke. But what we have not yet found is markers of that atrial myopathy which warrant anticoagulation, besides, of course, atrial fibrillation. In the ICAD study, they used ECG markers and blood markers, echocardiogram features, to try to find those patients who warranted anticoagulation. But unfortunately, in that study, I have not seen it published, but it was presented at ESOC earlier this year, those patients did not benefit from anticoagulation. That does not necessarily mean that this concept isn't right. There are other studies to be performed, and we'll hear about as time passes, which are looking at other ways of diagnosing this concept of atrial myopathy. And we hope that maybe with different criteria for defining what atrial myopathy is, we can avoid having to find the atrial fibrillation. But at the moment, we still need to find the atrial fibrillation before we know that we should anticoagulate. Which brings us to the question of when we find the atrial fibrillation, how long should we wait after the stroke before we start the anticoagulation? And the ELANS study, which I know many of you have already read, was published earlier this year looking at this question. Because until this time, we had what some people call Dina's Law. I think it was invented by Christina. 1, 3, 6, 12 days. We needed some idea of when to start anticoagulation, and Chris just came up with numbers which sounded reasonable. No one had any evidence to say he was wrong, and that's what we used for many years. But perhaps we thought we could be a little bit more prompt and start the anticoagulation even sooner. So what they did in this study is consider later anticoagulation following that previous standard of care versus early anticoagulation. And early anticoagulation in this study basically means anyone who hasn't got a full MCA, ACA or PCA territory stroke or a cerebellar or brainstem stroke more than 1.5 centimetres, all of those patients who did not have a stroke that large started within 48 hours. And all of the patients who did have a stroke that large started around day 6 or 7. They looked at the primary outcome being a composite of ischemic stroke and embolisation, and you can see in the box the other characteristics. And at the bottom of the slide is the image from the protocol paper, which describes what we might see on a scan for, on the left side, people who will start in the first 48 hours, and in the middle, the people who would start at 6 or 7 days after stroke. And what they found in the bottom of the slide is a statistically significant benefit from starting earlier in these patients, and all of the trends for the other secondary endpoints were towards the benefit of starting earlier rather than later. And this has certainly changed the way we do anticoagulation in our hospital, or much more aggressive, if you like, or comfortable is a better word, starting anticoagulation sooner after ischemic stroke than later. I'll say a few words about patent foramen ovale. There aren't any new studies, so I'll cover a summary of what the existing studies are in a few slides. And we're very used to the idea that a patent foramen ovale can allow thrombus to travel from the right side to the left side, as you can see in this image, and then embolise to the brain and cause stroke. Some of my colleagues will find a patent foramen ovale, and they will then do an ultrasound of the lower limbs to look for DVT. which is an interesting idea if we believe that the thrombus comes from the lower limbs, because as we know, many of the lower limb DVTs that our patients get are asymptomatic, and perhaps that's where the clot came from that caused a stroke. On the other hand, perhaps the clot that was in the leg is now in the head, so it's a difficult question about whether to scan. And what makes it even more complicated is the research which suggests that the patent foramen ovale itself can create clot. It can be a thrombogenic lesion in and of itself. And these are images from optical coherence tomography. They do a cardiac catheterization procedure and then image the patent foramen ovale, and you can see some in situ thrombus formation on the patent foramen ovale itself, which means the clot doesn't embolize from the right-sided circulation, it embolizes from the PFO. So that's a very interesting idea and might suggest why, if we do look at the lower limbs with ultrasound, we often don't find a DVT. For me, I don't do the ultrasound, I just arrange the closure of the patent foramen ovale. And here's a reminder of the evidence. It's very interesting evidence because several studies all showed the same thing, which is quite reassuring for those of us who want to proceed to PFO closure. We, in my centre, don't think too hard about the high-risk features. Most of the patients that we see, if there's a PFO, we will proceed to closure. And then there's many characteristics about the patients who are included in the studies which are not quite clear about whether they need to be strictly adhered to. For example, the timing of the PFO closure, you can see in that fourth row down, was up to 6 to 9 months after the stroke. But the patent foramen ovale is not like atherosclerosis, where it's hot and very embologenic, only very acutely after the stroke. One would imagine that if you have a PFO-related stroke at the age of 50, that risk will continue for the rest of your life. So one question is, should we close PFO if we only find out about it a year later? I'll also point out that we have not yet shown that PFO closure is superior to anticoagulation. And there were some patients who were anticoagulated in the closed study, one of the studies from the previous slide, but not very many, and not enough to show that anticoagulation, not enough to show that PFO closure was superior to anticoagulation in those patients who already need anticoagulation. For example, if they have atrial fibrillation. So we always look for atrial fibrillation before we close the PFO. And that raises the question, how long should we look for? And some colleagues and I put together a paper which suggested how long we should monitor for atrial fibrillation for before closing the PFO in cryptogenic stroke. And the general concept is that for older people who are more likely to have atrial fibrillation, that we look for a longer period of time, and younger people we don't look for as long. And for those people who we think are more likely to have atrial fibrillation besides age, which is probably the strongest risk factor, we also look for longer. So those patients we think who have high risks of having atrial fibrillation. I'll talk a little bit about left atrial appendage occlusion. So there's several ways of securing the left atrial appendage, and we believe a lot of the emboli which cause stroke that come from the left atrium in atrial fibrillation originate from the left atrial appendage. We don't necessarily believe that securing the left atrial appendage will prevent all stroke, but the aim, as with the first few slides, is to reduce the risk of stroke from the left atrial appendage and left atrium low enough that the patient no longer benefits from anticoagulation because the risks now outweigh the benefits. So we have randomized controlled trial data which mostly compare left atrial appendage occlusion, so percutaneous occlusion by an interventional cardiologist, mostly versus anticoagulation, certainly in the first few weeks. That's not how the interventional cardiologists often practice these days. They, certainly in my centre, they do not use anticoagulation after a closure. They'll use antiplatelets. But nevertheless, this is what the RCT data showed us. And in the right column, there's also RCT comparing two of the most commonly used devices on the market. And the general concept or the general summary of the slides of the studies is that left atrial appendage occlusion is probably better or at least as good as anticoagulation in those patients. Those studies, as I said, compared warfarin, and we don't use warfarin very often in atrial fibrillation these days. So we needed a study comparing left atrial appendage occlusion with NOAC, because that's our usual standard of care for patients with atrial fibrillation. So that's the most appropriate comparator. And in the Prague 17 study, the left atrial appendage device was compared with one of the NOACs, although most of the patients in the study received apixaban. And they did show that left atrial appendage occlusion was non-inferior to the NOAC usage. And so we had some data which showed us that left atrial appendage occlusion was at least as good as warfarin. We still don't know whether or not the use of antiplatelets instead of anticoagulation after implantation affects the risk of device-related thrombus. We think that amulet and Watchman devices are reasonably equivalent, and in a Prague 17 study, left atrial appendage occlusion was non-inferior to NOACs. So there's several options now for how to manage people with atrial fibrillation, including with anticoagulation and with left atrial appendage occlusion. And so some colleagues and I put together some opinion for the Asian Pacific region about which patients should be offered left atrial appendage occlusion. And I won't go through the paper in detail, but the sorts of conclusions were that we probably should not offer the procedure as being equivalent to anticoagulation to the average patient, but very reasonable to offer left atrial appendage occlusion in any patient who has had or is likely to have problems with anticoagulation, for example, due to high bleeding risk. So that's the data in very brief terms about occlusion from the inside of the heart. But the left atrial appendage can also be secured from the outside. It can be excluded, although in this study they called it occlusion. But this is the trial looking at when the surgeon is doing cardiac surgery for other reasons, should they also oversew or otherwise secure the left atrial appendage? And in this study, the patients who had the left atrial appendage secured did better than the patients who had it left alone. So quite often in the hospitals that I work at, if the patients are having heart surgery for some other indication, for example, bypass grafting, the cardiac surgeon very commonly will occlude the left atrial appendage, predominantly in patients with atrial fibrillation. And then another way of securing the left atrial appendage is epicardial clipping. And this is a procedure done independently of cardiac surgery. So this is a procedure done purely to secure the left atrial appendage and not in people who are having cardiac surgery for another reason. So they will electively have this thoracoscopy, and the procedure will include this clip, for example, atrial clip device being placed around the base of the left atrial appendage to stop blood flowing in from within the lumen to therefore prevent clots. So theoretically this has some advantages. Obviously there are disadvantages. This is a minor procedure, but it's still an operation, and you can see in the top left-hand box there is an incision in the skin, and the operator has to move into the thoracic cavity to do the procedure. But the other potential advantage of this approach is that there's no foreign material left inside the heart. So there's no thrombogenic foreign material within the heart that might cause device-related thrombus and therefore discount the benefit by creating clot. So in conclusion, there's ongoing research to understand which patients will benefit from anticoagulation, and we're still looking for markers of atrial cardiopathy or atrial myopathy which define those patients besides atrial fibrillation. We no longer have to follow the 1, 3, 6, 12 rule. The ELAN-based rule is easier to remember and only has 2 grades and is much shorter and more prompt. Patent foramen ovale related stroke doesn't necessarily mean embolization from the legs because the thrombus can form within the patent foramen ovale. And we have good evidence that we should proceed in patients who have PFO if they meet those other criteria that we talked about in that previous slide, with some guidance about how long to monitor for atrial fibrillation before proceeding to PFO closure. Percutaneous left atrial appendage occlusion in atrial fibrillation is becoming more and more commonly practiced, and there is guidance in the region that we work in, but there are other options for securing the left atrial appendage, for example, during cardiac surgery or as a standalone epicardial procedure on its own. Thank you very much.
Okay, thank you for excellent presentation. Xin mời các quý đồng nghiệp có câu hỏi gì cần đặt ra cho báo cáo viên.
Tiếp theo chúng ta sẽ nghe một cái chuyên đề cũng rất là hay là những tiến bộ trong điều trị đột quỵ giai đoạn cấp và bán cấp, vai trò của Cerebrolysin đối với bệnh nhân đột quỵ cấp. I would like to invite Professor Alexandrov from USA. He is presenting this topic. Thank you.
Thank you very much. I really appreciate this invitation to come back to Vietnam and see its great improvement over the years. Thank you. My disclosures are that I am not in charge of medical mobile stroke unit at the moment, just because I moved from Memphis to Phoenix. And I can claim that I'm the oldest person or with the longest experience in giving Cerebrolysin in this audience. I gave it first in my first week of working as a doctor in Russia in 1989. First week I treated a stroke patient with Cerebrolysin, and also we did one of the first, and we monitored these patients with brand new EEG mapping. So having said that, let's have a quick quiz. So what's the first approved stroke therapy, or I should say not first approved stroke therapy, but what was shown as the first effective stroke treatment? It was not IVTPA. What was it? It was interdisciplinary stroke units. There was a paper published in '91 by Norwegian scientist Indre Davik, and basically showing that if you take all folks from doctors to nurses to physical therapists, speech therapists, and you bring them together to provide stroke-specific care instead of being admitted to a general ward, that stroke-specific care basically reduced mortality and improved disposition of these patients. So TPA was published and approved in '95. We started to give it in '96. The Joint Commission introduced primary stroke centers in 2004. In 2013, we launched comprehensive stroke centers in the United States. Interestingly, just preceded by 1 year Mr. Clean results that gave us evidence, first trial gave us evidence that thrombectomy works. We're right now engaged into rearranging hub and spoke systems in the United States. And the trial that I'm going to give you first update is BEST MSU trial that was presented, unfortunately, during pandemic in a kind of clunky ISC that was totally online, so I will show you these results. But where is mobile stroke unit relative to all of that? So this is the first mobile stroke unit. As a concept, Klaus Fassbender published it in 2003, and in 2008, the first German mobile stroke unit entered the scene. Okay? And so now here is the inventor. This is Klaus. And on the right, it's the Berlin mobile stroke unit. I will touch base on their study. And so the idea was to take portable CAT scanner that's just dedicated to the head, put it on an ambulance, and bring stroke expert to the patient in the field with paramedics. However, just out of curiosity, do you know what really first mobile stroke unit looked like? It's this. So do you guys know what EMI is? So this is the CAT scanner. What is EMI? It's the record label, Beatles. So this British company had money printing machine, and so they invested into Sir Hounsfield invention, and they built the CAT scan. But when the CAT scan was built, no radiology department had a footprint to put it in. So the company put it basically on a truck and was driving CAT scans around Manhattan to show physicians how advantages are of scanning the brain look like. What we should have done, probably, Steve, we get it when you were doing, you were at Harvard at that time? You should have taken it and put a streptokinase or whatever, urokinase at that time and start giving it. It would have been settled even before we started the whole stroke thing. All right, so but fast forwarding over 30 years, close to 50 years, as a matter of fact, of the CAT scan. So here is the best MSU study, and this is our investigative group. So these are mobile stroke units in the United States, from New York to Los Angeles and from Chicago down to Houston. And here is my group at that time at the University of Tennessee. So we operated this study as week on, week off, because you cannot blind the patient to the mode of transportation. So we didn't pretend to cover up our mobile stroke unit and do controlled study that way. We just operated a week on, taking patients through mobile stroke unit, and then we will rest a week, and patients were transported as regular paramedics. And at the end of the day, we had altogether evaluable subjects. And I'm just going to adjust the screen here a little bit. And so they were balanced at baseline in terms of their severity and proportion of patients. And what we were interested in is how often we were giving TPA in that setting. Did we miss an opportunity or not? How early we were giving the TPA, how safe it was, and what were the 3 months outcomes. So first of all, we, of course, noticed that on average, we treated the patients 36 minutes earlier than by average transportation. And most importantly, if you were transported by mobile stroke unit, you were 97% chance likely to receive TPA if you were eligible, compared to just 80% if you were going by regular paramedics. So having first contact with an expert, that's what makes a difference. Whether it would be direct doctor on the unit, telemedicine on the unit, or nurse practitioner on the unit, regardless of configuration, you will likely to get treated. Secondly, not only you are more likely to be treated, you're more likely to be treated super early. And what is super early? The time is brain, and imagine if you can give the medicine to the patient within 60 minutes of symptom onset. And so mobile stroke unit accomplishes exactly like that, from 2.6% on a regular ambulance. So almost never you get to the chance to treat the patient early, up to a third if you pick it up on mobile stroke unit. That's a huge advantage. And because you're giving it consistently and super early, as a result, you can see improvement in a modified ranking score, that your chance of excellent outcome, meaning modified ranking score 0-1 at 90 days, is over 50%. And that is in the study targeting TPA as the main treatment. We were not powered to look at thrombectomy and some other things. So that, actually, we had a glimpse of that through the Berlin study. And I'm going to show you, going back to the Berlin STEMO, that's their name for mobile stroke unit. Here's the map of Berlin, and all the dots are all the stroke centers that they have there, primary or comprehensive. And as you can imagine, there is a lot of competition in town. So how did they navigate? Well, you can, their study was looking at not only patients who were getting TPA, who were thrombectomy candidates. They looked at everybody whom they transported. And here's how their patient population looked like. So first of all, 1 in 7 had TIAs. So they were transporting TIAs. That's a good outcome to begin with, right? They were giving TPA, not as high as in best MSU because they included all patients whom they picked up. Their golden hour was only 12 patients, 13% roughly. And thrombectomy rates did not differ between regular transport and MSU. So that in itself does not explain why they similarly had such great outcomes. The conclusion that we made from that study was, interestingly, that the concept of mobile stroke unit is very reminiscent of the concept of specialized stroke units that we had in '91. So you have access to stroke expert and person who cares about stroke very early on, skipping the route of paramedics, skipping visit to the emergency room where somebody else who doesn't specialize in stroke looks at you. And so together with Leung, he is the director of mobile stroke unit in Bangkok, we wrote this kind of reflection on Berlin study and saying we welcome that result because you should not modify your stroke care systems to benefit just TPA candidates or benefit just mechanical thrombectomy candidates. You need to have a concept, no stroke left behind, because even if it's a TIA, even if it's a minor stroke, even if it's a stroke mimic, your quick access to stroke expert is the key to initiate proper stroke treatment. And I think that's the message from the Berlin study. Furthermore, here's the map of mobile stroke units. So if you are interested, please visit prestomsu.org. That's the website. And here's Dr. Davis's unit down in Melbourne. We have a couple of units in Southeast Asia, notably Bangkok organized. So if you wonder how they navigate the traffic of Bangkok, I think it's worse than it is in Ho Chi Minh City. Last time I've been there. Just to give you a hint how they operate in Bangkok, they do not go to the patient location because most of the time it's too difficult to navigate through traffic. And what if it's a high rise? So they are letting the local responder get the patient out. They talk about location and they drive to the nearest gas station. So interestingly, the owner of the gas station is a very rich guy, heard about this concept, and he allowed mobile stroke unit to have a parking space at each gas station in town so they can pull up, get the local responder, bring the patient, do everything in a controlled environment, even refuel, and get the CAT scan, start the TPA, and then bring the patient to thrombectomy center if there is a suspicion of large vessel occlusion. So don't give up on your city just because you have bad traffic situation, okay? There are solutions. All right, so that's an update on mobile stroke unit, and just to mention and plug it in, it is a great opportunity for research. You're gonna get to try the newest and the best from hemorrhage treatment to pre-hospital diagnosis to faster evaluation. So, and our colleagues in Australia are actually doing some of the very innovative trials. All right, so having said that, let me shift gears back to Cerebrolysin. And the story there is very interesting. I'm just gonna show this slide from Pat Leiden's publication, but the whole concept of neuroprotection kind of went a full circle. So we first were discovering mechanisms of ischemic cascade and finding molecules that will turn off that part or turn off this part. And the initial approach was to find one molecule that will just protect neurons, buy you time, improve outcome. And as Dr. Davis has one of my favorite slides in his collection. that neuroprotection is an approved therapy in rats. So $1 billion research, over 1,000 approaches tested, and yeah, it works in animal models, but when it comes to clinical trials, it invariably failed. So interestingly, in the 50s, a Austrian scientist had this idea. Well, we don't really know yet at that time how ischemic cascade occurred. In fact, we were just basically knowing about calcium influx and maybe cerebral blood flow reduction and what happens there. But the idea was that if the brain is in need, if the brain is being injured, what if we give the brain irreplaceable things like amino acids and neuropeptides and kind of bring the whole menu, like here it is, whatever it needs, just pick it up and use it for repairs, use it for kind of delaying ischemic damage. And that's how cerebrolysin was invented. I remember as a first week on stroke service, we were told, well, this is just 50 different molecules that brain may need. We'll just give it as a shotgun, and it is a potent kind of approach. We don't know exactly what it's going to need, but it will get what it needs. And interestingly, now, as a circa of 2020, this approach from a single molecule to polypotent cerebral protection, not neuroprotection, neurovascular unit protection, this concept re-emerged. And these are just few statements from Mark Fisher and the STAIR group that came to basically saying that we need to not just cytoprotection, we need neurorestoration, we need to protect neurovascular unit, we need to protect cerebrum as a whole, providing essentially combination therapies that will work acutely as well as facilitate repair and neuroregeneration days and weeks after stroke. And particularly, there is a need to further improve outcomes after intravenous TPA as well as mechanical thrombectomy. So just remember, even in the best hands, complete recanalization is not guaranteed, that's number one. And even if you had complete recanalization, you often do not see brain recovering completely. So you need to get additional support, additional protection to those folks. And cerebrolysin, interestingly, invented kind of as a shotgun approach, was later on studied in Michael Chop's lab and others, and they showed that it has multiple mechanisms of action, from protecting brain-blood barrier acutely, and I'm going to show in the second lecture data on reduction on hemorrhagic transformation. I may mention it here as well as in the second lecture, and then fostering neuronal repair and helping neuroregeneration later on. So in the preclinical study, it actually helps with endothelial cell function and can protect the reperfusion period from increasing extravasation of blood products and reducing the chance of symptomatic hemorrhage. And so here is an example of reduction of blood-brain barrier permeability in the animal models. Also, this is a mention of the rehab review published in Lancet Neurology that basically said, yeah, all trials of technology in neurorehab at the moment are neutral. More intensive PTOT is neutral, but the first pharmacological assisted study in neurorehab was positive with cerebrolysin. So which study was that? Well, it was CARS. And I will briefly mention what happened in CARS. So a Romanian professor, Dafin Mureșanu, had this idea. So why would we be testing neuroprotective trial in unselected stroke patients, often with mild stroke severity, and at the end only to see that they're going to recover anyway? What if we take patients who are in most need? And patients in most need are those who have arm plegia or significant paresis. And using Flügelmeyer or Arad score, you can actually trace that improvement very clearly in the first 3 weeks of stroke in rehab, with or without aid of cerebrolysin. And so that concept resulted in a publication of CARS trial in stroke, showing early and sustained improvement of ARAT score. And then it was replicated in subsequent CARs and meta-analysis. And because the worldwide distribution of the drug or access to the drug, we have the following interesting things. So we have Austrian guidelines, Canadian guidelines, and German guidelines that endorse this. But the rest of the world is kind of in between. And so my personal problem is that I have experience with cerebrolysin, but in the United States, it's not yet approved. But the guidelines started to respond to the evidence that is out there. So the challenge to international community is find the way how we can make it available or recognized across Atlantic, across Pacific in different countries. So here is the, for example, Canadian stroke rehabilitation guidelines that endorse it at a very high level. There is a European Academy of Neurology that specifically quotes results of the CARS trial, saying that if your NIH stroke scale score is 8 or greater with a significant arm weakness, this is an ideal patient to receive 3 weeks of cerebrolysin along with rehabilitation. And you should start this early, within the first 7 days of stroke. And then if you project those guidelines that I mentioned to AHA, we should at least ask AHA to review that and maybe comment that we have at least 2A level in support of cerebrolysin. So I would stop here, and if you have any questions, I will be happy to answer them. Thank you.
Vâng, xin cảm ơn báo cáo của giáo sư Alexandrov. Đề nghị chúng ta có câu hỏi gì?
Andre, thank you very much. Concerning cerebrolysin, if you were writing the guideline for the World Stroke Organization, tell us the guideline for use of cerebrolysin.
Steve, I didn't hear you.
Sorry, give us the guideline. You've said in some countries or regions cerebrolysin is approved as therapy. What would be, from your point of view as an expert in use of this agent, what guideline would you recommend? You know, how long after stroke, which patients?
Right. So the actual development program of cerebrolysin continues, but it continues with efforts like in Russia, in Mexico, in different countries, Austria for that matter. The studies that we have that show very strong signal, for example, is reduction of hemorrhagic transformation after reperfusion therapy, whether it's intravenous TPA or thrombectomy. So I think that's kind of the key right now that we can promote and perhaps do a multinational registry. Again, I'll be talking to the sponsor if they can afford doing such a study. And then if you are giving it acutely to reduce the risk of hemorrhage, you might as well give it to patients with significant measurable deficits, such as motor deficit, to reconfirm CARS, and that can help with transition to early rehab. And I think these are two key points: so protection acutely and increasing neuro recovery.
Như vậy chúng ta đã thấy rất rõ là cerebrolysin, nhất là trong trường hợp nhồi máu và có chuyển dạng chảy máu, cho nó dùng thì nó giảm được tỷ lệ chuyển dạng chảy máu, nó giảm được cái nguy cơ đột quỵ. Xin cảm ơn giáo sư. Thank you. Phiên này chúng ta chắc đến thế là kết thúc. Xin cảm ơn quý đồng nghiệp đã nghe.